When you hear psychiatrist, you might think medicating mental illness, but there's more nuance to it than that. Psychiatry brings together biology, psychology, medicine, and lived experience to understand what's going on in someone's mind and how to treat it. Aleem is a Pakistani Australian who migrated here 16 years ago, became a psychiatrist, and in doing so recognised a major need to increase access to psychiatric services, particularly for people in regional areas. He's since founded HelloDoc, a nationwide telehealth service connecting thousands of people with psychiatrists across Australia. We discuss the ins and outs of psychiatry, where medication fits in, how culture shapes the way mental health is understood, why so many adults are being diagnosed with ADHD later in life, and more. This is Aleem Khan. Welcome to Young Blood, the volunteer video podcast dedicated to young men's mental health. I'm your host, Cal McPherson, and this is a platform for young men and their loved ones to share lived experience stories and show that no matter what you're going through, you're not alone. Suicide is the number one killer of young people, and changing that starts with speaking up. So let's do it. This episode is proudly brought to you by Credit Union SA, a South Australian business that believes in the value of promoting mental health, working together with us to help save lives. Sharing lived experience stories is a major part of making a positive change, and we couldn't bring you these podcasts without their support. Aleem, you're the first psychiatrist that I've had on this podcast. I've spoken to psychologists and counsellors and psychotherapists. Can you explain what a psychiatrist does?
Psychiatrist is a mental health practitioner, specialist in mental health, and we do all sort of assessments, diagnosis, and treatment of all sort of mental health conditions. There is subspecialties in psychiatry, forensic psychiatry, old age psychiatry, child psychiatry, and so on. And then there is general adult psychiatry. So from diagnosing to treatment and everything in between.
How does it differ from a psychologist?
So psychologists mostly would focus on a talk therapy. So they will have different sort of therapies, like you may have heard about the common one. CBT is one of them. There is other specific therapies for example, PTSD, obsessive compulsive disorder, or some personality structures. So there are specific therapies which we would recommend. So psychologists will usually do talk therapy and treat the condition through the therapy, whereas psychiatrists can also prescribe medication. Some psychiatrists would do therapy as well. As a psychotherapist, they do usually do subspecialization in that, but most of the psychiatrists you will see will be more about assessments, accurate diagnosis, and then treatment with medications, and also basically recommending what sort of therapy the patient will need, and that therapy can be done through the psychologist.
How does someone access a psychiatrist or come to access a psychiatrist?
Most psychiatrists will require a referral from a general practitioner for a couple of reasons mainly. One is that if you're eligible for Medicare rebates, you don't get that without in private psychiatry without a GP referral. And secondly, if you're going to see a specialist, you need a referral from a GP. Because the specialist would like to understand what's the problem, what's the background, what's the medication, and all previous history and so on.
How does a GP know to refer to a psychiatrist rather than to a psychologist?
Generally, the GP would know their patient well. If it is a mild condition, for example, anxiety or depression or stress mood, or somebody trying to adjust with the changes in their lifestyle day to day, something like an adjustment disorder, so mild to moderate condition, the GP will generally refer to a psychologist because that's the first line of treatment or therapy. There is something called mental health care plan. The GPs can do that if the person fits the criteria of Medicare, and then a patient can go and see a psychologist, have a chat, do the therapy. If the condition is becoming moderate or moderate to severe, that's when most GPs may refer to psychiatrists for their opinion. Majority of the time it may be for opinion and management advice, so diagnosis, clarification, what way or what direction the GP should be taking the management to. It may be just one-off review for more of a diagnostic clarification and medications management, or it could be that GP needs help of the psychiatrist to continue managing the patient. Conditions like bipolar, schizophrenia, or psychotic disorder or mood disorder, they are generally better managed through a psychiatrist. GPs generally would manage anxiety, depression, mild to moderate conditions by themselves. But if there is a complex picture, multiple medications, or the condition getting severe, then GP would usually refer to psychiatrists for their opinion.
And are GPs generally well equipped to make that assessment fairly accurately to be able to refer people down the right path on the first attempt?
General practitioners are specialists in their field, and this is their bread and butter of daily life. So they see. I was speaking to a few GPs, and I've spoken to so many GPs in the last few years. 40 to 50% presentations in mental health in general practice is usually related to mental health. So people require medication, or people coming up with anxiety, depression, or all the common prevalent.
Has that been increasing?
It has been increasing, unfortunately, yes. It wasn't that high rate a few years ago. In the last 5 to 10 years, it has increased. So GPs are very well equipped, usually, to recognize. They are specialists in general practitioners. So this is their expertise to whether they can treat themselves or they refer it on to the other specialist colleagues like psychiatrists or psychologists.
Do you think that represents a cultural change, that more people feel that they can come forward and access mental health services, or that they recognise that it's a legitimate thing and that they should go and get help, and that's positive messaging getting through? Or do you think it's the case that people are struggling so badly with their mental health now, or is it both?
I would say it's both and even more. One good thing is awareness. So awareness is definitely increasing, and that's the first step. So whether it's through social media or news, or talking, or apps like TikTok and Instagram and Facebook, while they all have a negative impact, they also have some positive effect as well, like positive news spreading, awareness being spread, and with that awareness comes the first step of asking for help, which probably was not that much a few years ago. So people are have started asking for help. People have started going to the GP and taking the first step, because first step is the most difficult one. So and that's increased, obviously, and so is the conditions prevalence has also increased, like anxiety and depression is becoming more and more prevalent. Access to services is lesser than before. There is more number of people who need more mental health resources, whether it's psychologists or psychiatrists or social workers or other allied health services. But unfortunately, the demand is increasing, the supply is getting less and less. So that is also another thing, that people don't have any other place to go. They will go to their GP for help.
And it's one thing to come forward and ask for help, and it's another thing to actually get the help that you need. And a lot of people feeling let down by the system if they are brave enough to come forward and put their hand up and say that they need help, and then they feel like it gets thrown back in their face, or that they get ignored, or they don't get out of it what they were hoping to get out of it. And then we know that can discourage people from continuing to try to access services.
That's a very good comment. You're right. Many a times it happens, especially when there is, I know you talk a lot about men's mental health. So especially in genders, men, for example, it's not easy to ask help. Then in some cultures, it's not easy to ask help. Once you go that pathway, the first step is very difficult, but disengagement after the first step is also something that we do see a lot. Whether it's because they took the first step, they saw the GP, they saw psychologists, they saw psychiatrists, whoever they saw, and they didn't get the opportunity to engage well, they didn't build that sort of therapeutic alliance, or whatever happened, and they just didn't take another step, and they sort of left it there. So that's definitely there as well.
What's your cultural background?
I come from Pakistan, so more Southeast Asian.
How has your cultural background shaped your own views and approach to mental health?
It's very different to what I see here. If I compare this culture to my country of origin, it's quite different. There is a lot of beliefs, whether culturally, religiously, mental health is not considered one of the main problems. People would rather not talk about it, hide about it, whether it's depression, anxiety, or severe mental illnesses like bipolar or schizophrenia. A lot of the time people would either ignore it or just say, man up and move ahead. Everybody else is struggling as well. There are more struggles to put bread on the table rather than, worrying about and feeling anxious. So people are in the sort of fight and flight situation all day long. Everybody is doing that. People may actually revert to going to a religious scholar if they are having serious mental health condition like bipolar or schizophrenia. They may take a family member to a religious scholar rather than taking them to psychiatrist. They may feel it's more of a taboo to see a psychiatrist. If, for example, magics, spirits, all that stuff may be considered rather than mental health condition. To tell you a funny thing, when I started my training as a psychiatrist, my friends from back home, they actually sort of joked about it that who's going to go to a psychiatrist because it's not that important of a specialty back in Pakistan and all. But I liked it. I loved it, and I'm enjoying it since I joined my training and since finishing and all. So that's different, completely different from what we see here.
What's at the core of that attitude in not looking at mental health as being legitimate within that culture or profession like yours for being legitimate?
The lack of awareness is one big thing. So if you don't talk about it, if you don't talk about in media, social media, influencers, podcast and all that, it's not happening there. So things have improved, but still people would not understand that, somebody being down and depressed can be legitimate, and they are actually, going through a tough time and they may need support. There are support systems. On the brighter side, there are support systems like family networks are much stronger. You don't need, a proper social worker. All your family is working as a social worker, basically. So there are some good things about the cultural aspect there. So people would be supported through their family network, siblings, parents. You look after your child until they have grown up and started earning and all, and then the child looks after their parents until they sort of die and pass away. So it works very well in that embedded culture.
But from your experience, when people bring forth mental health issues to people close to them, to their family, what kind of response do they get? Do they get rejected or chastised for it, or do they get, obviously this is a bit of a generalization, everyone's different, but in general, from your own experience and what you've seen?
I think the biggest challenge is somebody bringing that issue forward and talking about it. You don't really talk to your parents or family or friends about feeling down or depressed. But if somebody does come forward, they can be maybe not taken that seriously. They may be taken that, it's okay, just chin up, go to work, make the living, and everybody goes through hard time. People may not understand that the person may be going through severe bout of depression, for example, or they may actually need real serious help there and then. There are, situations here as well. I've seen, similar things. Families sometimes may not understand that their child or their, sibling or their partner may be going through a lot. So this is, many a times I see that here as well, with lack of awareness or lack of understanding, or, unintentionally. But, people don't seek help.
But your family can't support you if they don't understand what you're going through, but also You're not going to come forward to your family if you're expecting them to not understand and
judge her
and knock you back.
Yeah.
So that's a tough spot to be in.
True. And judgment can be real. It can be, you may not be taken seriously. So it may be culturally, you may not be taken seriously. And then there's the resources as well. We still have a lot of resources in the Western world, in Australia, in this part of the world. You see a lot of resources. You see psychologists, psychiatrists, social worker, and you name it. There is all sort of principles, but you may not see that many specialties around in the Middle East, for example, or Southeast Asian countries. People would believe, if you had a fracture or heart condition or something, and they will help you and they will, do everything they can. But if you were telling them that you had anxiety and you can't get out of the house for some reason, or you had depression, or you were struggling with bipolar, manic or depressive episode, it's hard for them to understand, comprehend, and offer help.
So they might just categorize someone as being crazy or being weak.
Yeah.
It's still quite brutal in that way, or just a lack of understanding compared to some other cultures.
Both lack of understanding, awareness, and probably if they understood, they're very well-meaning usually because it's a close-knit culture. If they understood, if the awareness was there, you will be supported fully, and the awareness is growing and getting better. But if they didn't understand, they can't, obviously offer help.
So how does that manifest? What's the impact? Obviously, we're all human. Doesn't matter what our ethnicity is or where we are in the world, we all face a lot of the same issues, and you wouldn't find a person on earth who hasn't gone through something or is going through something. So what's the impact of that, not being able to share how you're actually feeling, and just having and we're not much different from this in the West, but a culture that's predicated on suppressing that emotion and just getting on with it. How does that manifest in people?
Yep. So as psychiatrists, we do know the longer you keep things bottled up, the longer you leave mental illness untreated, the severe the implications would be. Severe and difficult it would be to treat the mental illness. The severe, and it will be very difficult to get the person to back to their usual self, treat the condition. One of the unfortunate thing is that people leave it till late to get help, and that's where the problem comes in.
What's been your own experience with navigating your mental health throughout your life? I think it's pretty interesting that coming from Pakistan, where this isn't seen as a thing that people get into and do, that's sort of frowned upon in a way. It kind of been easy to choose that as a life direction. So you must be passionate about it.
Absolutely. I've been living in Australia for about 16 years now. So it's almost half of my life. And all my training has been here in medicine and then in psychiatry. Interestingly, I didn't choose psychiatry as my first go-to. Not until I actually did a rotation. So as a junior doctor, you go and do some rotations in psychiatry. So until I did a rotation in psychiatry. Until then, I wasn't actually looking into becoming a psychiatrist. It's actually when I did the rotation, I worked for about 3 months in a far rural area in Queensland. And that's when I realized that, this is something I really wanted to do and I was passionate about. The engagement I had with my patient, the engagement I had with my families, I didn't have that when I was working in any other fields. I mean, every other specialty is great and helping everybody, but I felt very connected with the people, with their family. I felt that, there is no other specialty where people will come in and they trust you so much that they open up about everything and anything in the most vulnerable of their moments of their lives. They trust you with that. So you got to be very, sort of present and able to help them and be there for them. So I felt the connection with the specialty, with my patients, and I adopted this as a specialty. Obviously, it's not a piece of cake or easy to go into the specialty and train and all. There were difficulties throughout the career, and especially I was trying to set up something, the telehealth platform that we built in over the years. So that was something that I got very passionate about. Looking at the access, especially in the rural areas, I could see that there is not much available for people to access psychiatry. Not only in the metro areas where there are multiple specialists and psychiatrists around, you still will struggle to find a psychiatry appointment for 6 to 12 months. At any given time. But if you are in rural area and you had to drive like 200 to 300 to 400 kilometers to go and see a psychiatrist, it's not easy. Firstly, you won't get an appointment for forever. 6 to 12 months is, I would call it forever, because by that time you're waiting and things can get worse. And then if you do get an appointment, it's too far. Access is a problem. You have to leave everything else. You have to go on a drive and all. So it was very difficult for me to see that, there is that big gap in the access for patients. So that's where I developed the telehealth platform as well, because there was the idea, there was the passion, there was the sort of interest and passion to do something different.
Is any part of it personal? Have you navigated your own challenges?
Like you said earlier, there is no one, probably majority of us, would feel down moment and or stress and fatigue and all. Obviously, I have spoken to psychologists for myself. I have been to a psychologist to see them when things are difficult and all. But that doesn't mean that it's something that being a psychiatrist doesn't mean that you can't go to another psychiatrist or specialist. So the passion was more about looking at people, getting the access, and the passion came in because there was no access for patients. There has been moments when you get really burnt out, fatigued, tired, when you are having a family and you are working through your training. The exams are difficult. Work is not easy. Training is difficult. So you do get burnout. You do get fatigue. But I've been able to navigate things fairly reasonably well throughout.
Have you changed your attitude towards mental health and getting help throughout your life? And coming from where you came from with that attitude being prevalent to now being a psychiatrist and accessing services yourself, like did you used to have a different point of view?
I think that's probably changed a long time ago personally in me. Very long time ago that was changed. I was very young when I left my country of origin and went. I've spent a few years in Asia, in China, and then I've been here for 16 years. So it's been a very long time, and the change of culture does happen where you live and what you adopt. So a lot of me have adopted the culture here in Australia. It's obviously been here for a while. It wasn't that difficult because all my medical training is from here, and then working in the field, my passion is about raising awareness, telling people, whether it's back home, if I speak to a family member or if I speak to somebody else. Obviously, I'm not consulting there. I'm not a practicing doctor there, so I only practice here. So if I'm speaking to anybody, family, friends, or if I go visit there, my main intention is to raise awareness, tell people that this is something you should be talking about. You should be talking to other people around. There should be more and more services and all.
Has that shifted your family's attitude around all this at all? You being in the position you're in?
I've been able to change that many years ago. So it also depends. I forgot to mention one thing. It depends on which side of country or rural area or metro area or what sort of background you come from. And it's the case here as well as any other country. If you're living in a rural area, the way that you live, the way you understand things, the culture is different to when you're living in a city area. Different socioeconomic status, different accesses to the systems will mean that your understanding about the services, about the mental health condition or medical conditions will be different. So I was lucky. I didn't have to convince anybody too much in the family, so they already understood a lot of it.
With them understanding that, have they shifted their own attitudes in terms of do they speak openly about mental health now? Is that something that is normal within your family that's occurred because of you becoming who you are?
I guess they do understand, accept, and if there is somebody who needs support, they will call out straight away. They won't be hesitant.
Okay, so you trained to become a psychiatrist. You saw the gap in services, particularly in rural areas. Tell me about founding HelloDoc and trying to fill that gap.
So it was about 6 years ago, just before COVID was starting. And I was training in a rural area at that time. And the access to psychiatrists, especially private psychiatrists, was too minimal. People had to wait for 8 to 12 months was the average time, and they had to travel at least 300 to 400 kilometers to go see the the psychiatrist in person. That limited their sort of availability. They didn't make that much. It's hard to make that much effort, and one has to be really unwell to get help from the public system. You have to be struggling with serious mental health condition to be able to get seen in the public system, and in private system the access was very limited. So that's where the idea of telehealth came in. So one of the biggest challenge I faced at that time was I was a trainee doctor, so I was a junior doctor, and I had to speak to very senior doctors who are specialist psychiatrists. I had to speak to them to convince them to work with me, work in my service, and be able to help people, be able to get the appointments. So that was one of the biggest challenge. But one way or the others, I was able to convince people, get them to work with me in HelloDoc, and the rest is all history. Since inception, we have been able to help tens of thousands of people across Australia, and that includes people from all genders, socioeconomic backgrounds, rural, remote. Our focus still remains on rural area because that's where people have limited access. We have been very proud to offer bulk billing appointments to people, to tens of thousands of people across the rural area, so they can access the services very quickly. We have been able to offer and access to people from First Nation, people from other cultural background, multicultural background, who may not have access or who may not want to go and make the second attempt. They may just come and otherwise may not make the attempt. Females who would not come across forward if they are single mom, low income earners. Men has been a big priority as well. It's very difficult to get men to seek help and call out for help. So when we see a group, people from specific groups coming in for help, we try our best to make sure if they come in, they speak to a psychiatrist, they get seen as soon as possible. And we have grown to becoming one of the largest telehealth, mental health telehealth provider in the country now. We're seeing very large number of patients across the country. And again, proudly trying to help as much with bulk billing or no charge to the patient.
So in the example of someone who would have had to have travelled 300 kilometres before and wouldn't be able to access help in the public system, and it would take them ages to get in, they wouldn't be able to get to the private system either. What's available to them now through your service?
Yep. So the first and foremost is as soon as they get a GP referral, they can get access to a psychiatrist consultation within days, not months. So our team is decent sized with psychiatrists, and there is more psychiatrists if we need it. If our wait time is blowing up, we'll get a new psychiatrist on the team. So we have managed to keep the wait times under 2 weeks since inception. So anytime you call HelloDoc and you need an appointment, you get an appointment within 2 weeks. That's the whole purpose.
So is that all face-to-face online?
Video conference, correct. So
Okay.
through video conference, all the appointments are done through video conference.
So you've got a lot of psychiatrists across Australia who are registered with HelloDoc, and then they also consult in person, but they do some online appointments?
Yeah. Depends on each person's, each psychiatrist's individual circumstances. Some are doing part-time, so they do public system 2 days or 3 days a week, and then they do HelloDoc 2 or 3 days a week. Some are working full-time, 5 days, 6 days a week sort of thing as well. Some are doing 4 days, and that's all they do with HelloDoc, and they take 3 days off. Some people have different responsibilities, school drop-offs and also they start after dropping off their kids, finish before picking them up, and then do another couple of hours and so on. So, but they're all available. It's a booked appointment system, so you have to be pre-booking the appointment. But all the appointments will usually be available within 2 weeks.
I was just thinking of it's like Uber for mental health, but it's not quite like that. But.
No, you can't. It's not on demand. It has to be pre-booked.
How many people have accessed HelloDoc?
Last year alone, we had more than 12,000 consultations.
Wow. And a lot of them would be people who otherwise
may not have
would get anything. You said men have been a big focus. Can you just elaborate?
Because men don't seek help very quickly. Because men leave it till very late. and there is not a lot of awareness. And then there is sort of a silent crisis going on in men's mental health. It's more about, nobody's coming up. Yes, things have improved for, which is a very good news in the last few years, but there is so much more work to be done. So from our service point of view, we do prioritize men's mental health. We got a number of psychiatrists to see a lot of men. Similar to many other, situations, gender, cultures, it's a specialty in itself. So to be able to understand men, what they're going through, it's sort of a subspecialty in my eyes. So it's very difficult to take the first step for men. All the taboos, all the stigma, all the false, misconceptions around, men being the breadwinner and, has to be strong and has to be this and that. And, men can't cry, men don't cry, men can't be weak. And then some cultures, men has to be the macho man of the home, you can't be weaker. So those sort of things, do come across as some very severe mental illnesses at some time, because again, the longer you leave it, the longer things are bottled up, the longer you don't get help and treat things, it becomes difficult to treat it.
How are things getting better?
With awareness, program like yourself, people doing podcast, social media. There are so many men's helpline services which are getting better. 5 or 10 years ago, you wouldn't see those things. You are now seeing them every day. Different people, influencers, people who have a name or people know them. They're talking about mental health, and obviously the services who can offer help. The number of services are increasing every day. So that's probably where there is a bit better improvement in there.
Is more awareness enough though? We can only talk about something so much if you don't have the resources there to help people when they realize, okay, yeah, I have been holding on to something. I feel like I should come forward and talk about it. If there isn't enough places for them to go to get the help they need, then we can talk about it all we like, but it's not, doesn't do what it needs to do.
I don't think we are even close to having enough services. If we were, we won't be facing almost 9 suicides every day in Australia, and 7 out of them being men is shocking. 75% of the deaths. So if we had enough resources, we could see the number dropping. So there is a lot more work to do. There's not going to be enough sources in the near future, but there are services much better than before. So there's a hope. We're not at a place where we can say, we got enough resources. We are struggling with mental health services across public and private systems across the country, and there need to be more resources. 2 things need to be there, foremost and most importantly, awareness, more awareness, as much awareness as possible. And secondly, people need to start coming out and asking for help. All men need to step up and step out and ask for help.
How do you see us possibly meeting that need as a nation in the coming years? When we talk about, we need more resources, like what do we mean? Do we need more buildings with psychologists in them, more telehealth services, AI, hospitals?
The changes need to be made on a system level. There are so many things that need to change. I'm not across the exact funding, but the funding for mental health services may be increased by government. Gender roles, more so similar to, if we think, okay, if I'm seeing a person from XYZ culture or XYZ gender or XYZ background, they may need a support person from the same culture. They may feel more safe. They may be able to open up and stuff. Similarly, men may feel comfortable with, men. More psychologists, more psychiatrists, gender-based. Some people come and tell me that, they want to see, men may want to see another man as a therapist. They may want to see men of mature age, for example, or some may say, I just want to talk to somebody who's similar age to myself or maybe younger to myself. So there's so many things that are still required because one size would never fit all. So there is more need for resources, men-specific resources. The numbers are alarming, like, 7 out of 9. It's an alarming number. There is so much needs to be done. Funding, resources, system change. Telehealth services can make a difference. Why not?
When you're actually working with patients, you have your initial consultation and you eventually diagnose patients, and then you're mostly working on their medication and refining that, and then also some talk therapy within that as well. Can you just talk about the process of first of all diagnosing someone and then refining their medication to get it to actually work for them?
Yeah. So I personally don't like labels. I don't get to put labels so quickly. By labels, I mean, diagnosing somebody with a chronic long-term mental illness like bipolar, for example. So if I'm meeting somebody for 30 to 45 minutes or 1 hour, I try not to put a label straight away, even if I have every, thing in front of me, histories there and stuff, because the brain is always evolving, especially in young people. When we see these sort of mental illnesses originating or starting, it's usually in the young people, 18, 20 years old. That's the high prevalence age. So I try to limit the diagnosis and just more so formulate what the person is. Who are they? What's their background? What is their predisposition? What's their risk factors? What is going on at this time? Why now? Why not 6 years ago? What am I going to do in the next 6 months? How am I going to treat it? And then obviously with medication, we rely on the evidence-based therapy. If we are recommending medications, they have their own protocols, which medication to go for. That is obviously optimized, or that's usually prescribed based on age, gender, medical comorbidities. There's so many things that you have to consider before prescribing medication. Generally, majority of the milder illnesses, the solution would be psychotherapy, psychology, but that's more general. With mental illnesses, the few things that are very important, and everybody talks about it, so it's very common, but we don't still incorporate that in everyday life. For example, sleep, very important. You don't sleep well for a few days, people will start getting irritable, angry, appetite, sort of eating healthy nutrition, sunlight, all those sort of movement.
So will you try to get people to adjust those lifestyle factors before going down the medication route?
Depending on the severity. If this is a moderate to severe condition, we'll like to treat with the medication. But if it is a mild to moderate condition, that's where we will like to put a plan for example, psychology, talking about, how much are you sleeping, how much caffeine are you taking, how much alcohol are you drinking, are you taking any drugs, how's your social connection, who you got in your social. So it's not just a treatment. Okay, you got depression, here's the pill, go and take it. That's not how it works. Mental health conditions are usually multifactorial. So there is usually some social stuff going on. So there is some biological, neurological, chemical imbalance in layman term that we call it, that's going on. So we got to look at every aspect before coming to a conclusion. And then, medication is not the only option. We got to fix those problems. Like I mentioned, sleep, movement, sunlight, routine is very important. And that's what we do in the therapy as well. Psychologists will talk about, behavior activation, routine and all that.
When is medication useful?
When generally, again, it may be different for different people, but generally when the function is involved, the function is being impacted by the mental illness. Excuse me.
Right, yeah.
Sorry about that. Can talk about the medications again. Okay. Generally, medications will be initiated when the function is impacted, sleep is impacted, or the severity of the condition is to the point where people are either not getting better or they are likely to get worse. Depending on the severity is probably one of the most important factor. The first approach is usually no medication. If medication are prescribed, That's less medication, one medication at a time, in the smallest possible, most effective dose, and then we optimize it. We will review the patient regularly, or the GP will review the patient, and then we go from there. So it really depends on that person. If they need medications, we'll prescribe that. There are conditions like, ADHD, for example, may not require medication if it's not impacting your function. Anxiety or depression, if you're going to psychology, you may not need medication if it's milder form. But if it's impacting your function, you're not able to sleep, you're not able to do much, then you need medication. If I give you an example, analogy, think of your brain as a traffic system, right? And all the hormones, all we talk about serotonin and dopamine and noradrenaline and all cortisol and all those hormones being the traffic light. So the system can be faulty. System may not need to be broken, that the lights may be disaligned and they are not functioning properly. So medications, what they do is basically they regulate those lights to start working properly. But if the lights were already working reasonably enough, you're not worried too much about the crisis or things are okay. You may just rely on therapy for that time. So it's case by case, person by person. Does the person need therapy? Does the person need therapy plus medication? Does the person now needs only medication? Situations like if you're in the hospital, a severe mental health condition, therapy may not work for that time. You may just need to rely on medications only at that time. So case by case.
There's around 4 million Australians that are on antidepressants. What do you think about the rates of usage being so high for those medications?
Yeah, one of the problem is prescribing too quickly. It's a human nature to want the results very quickly. Therapy comes at a cost of duration. It takes a bit longer. So sometimes it can be an easier solution to be on the medication. But that also represents the high number of people struggling with mental health as well, with depression. The other thing which we are working on, and whenever I meet my colleague, and I've attended a few conferences recently, there's a lot more education going on de-prescribing. So people would prescribe but forget about these prescribing. So you got to prescribe. There is a role of medication, but there comes a time when you may not need medication. The person may not need medication. There hasn't been much done into de-prescribing. In UK, there are de-prescribing clinics. We don't have them here. There might be some. I'm not familiar with many. So there has to be that sort of clinics as well. There has to be that sort of services where people, for example, if somebody's got a first episode of psychosis, general guidelines are 6 to 12 months of medications, but sometimes you'll see a person who had an episode 10 years ago and they're still taking medications. Majority of the time you will have people who don't take medication after a few weeks, but sometimes you'll see people who are actually taking it for many, many years.
So what could be problematic about that? People being, for example, on antidepressants, and they just stay on antidepressants and they don't have any path to wean themselves off or move beyond that. And they can obviously in some cases be extremely helpful. I've had people on the show credit medication for being an integral part of their recovery, and then other people on the podcast talk about how it just made everything worse for them. What is the possible drawbacks of staying on medication for a very long time?
Medications, all, if not most, medication come with side effects. The problem, the first question you asked was about, why they're still on or they continue to be on. Maybe that's because of the access to services, the limited time people have in even with a specialist appointment or GP appointment. So a lot of the time it's people will attend a 10-minute 10-minute consult with a GP, and that is all they will get. A repeat prescription, may not have the opportunity to talk about what's going on. So it's a whole lot of system. If the GP didn't notice or the patient didn't notice that I've been taking this medication for 6 years now, feeling well, is it time to get this prescription? Again, just very clearly, I'm not presenting any medical advice to anybody. People should consult with their doctors if they need to come off the medications at all. But this is more of a general, discussion and information. If they have been taking the medication for a long time, they can discuss with their GPs and mental health professionals that, is this the right time? is there another medication that's better off if they're getting side effect? If somebody's come to your podcast and they said they were having side effects, so if they approached a health practitioner, they would have been able to offer them a alternative management or another alternative medication or something that they may benefit while they are coming off the medication or having the side effects and all.
More people are being diagnosed with being neurodivergent later in life, so autism and ADHD. What does a diagnosis like that give someone, particularly once they're an adult?
Yes, we have seen in a funny way, people are calling it a pandemic, and I don't agree with that. But obviously, that the credit goes to the awareness. People, I tell you an interesting fact. When I assess somebody for ADHD, for example, or if it's an autism assessment, you look at their school reports if they have access to school reports. And there is black and white evidence written that the child is hyperactive, jumping up and down, distracting others, not able to sit still, haven't finished the task, all the tick boxes. And unfortunately, the awareness was not there. For example, at that time, they were treated as just naughty kids. And the life moved on. But if you compare neurodivergent people with neurotypical, if that's the right term to use, so you'll see that a person having ADHD had to compete with their class fellow when they were young. They had to compete with their workmate, a colleague, when they were working. They had to compete in the uni. They had to compete with their siblings. They had to compete with everybody. They had to, they were coming across. That not only been a problem for they obviously lacked attention or have hyperactivity or whichever subtype of ADHD, but that can also cause burnout. That can also cause depression, anxiety, and all. So that's why it's very important, whether it's late stages or early stages, to treat ADHD when it's diagnosed. Whether it's, again, milder condition, can be treated or can be having ADHD coaching or therapy like that. But if it's impacting your function, medication is a way to go. The word I hear in almost most of my days when I'm consulting, I hear from the patients with ADHD who are treated with medication is miraculous. So they say the medications are miraculous, and the second word is life-changing. So these are the two words that I hear every day when I'm consulting and seeing patients with ADHD. So these are people who are in their 20s, 30s, 40s, and sometimes in their 50s or 60s, and they are saying, my life is changed. I wish I had this treatment before. So definitely it makes difference, as if, a huge difference in their lives.
So in that context, it's good for them to have that label.
Yeah. Yep.
Yeah. Because you said before you don't always like putting a label on something or making the diagnosis overt, but in the case of neurodivergence, it's useful for people to see their life through that perspective.
Yes. So label, I wouldn't put a label on a person, again, even with ADHD in their first session with me. I'm very careful with that. So my way of assessing ADHD is very comprehensive and very thorough, and that's what we do with all our psychiatrists working at HelloDoc as well. We take usually 2 sessions to understand the person, at least 2 sessions. They're 45 to 60 minutes long usually, and we not only get to know the person very well throughout their, since their development all the way till the day of assessment. We try and most of the time speak to their family members. We look at their school reports. We get their physical health checkups, their blood test, ECG, urine drug screen. All that stuff is done. So it's a thorough review. It's not just, a churn and burn. It's not you come in and you get a diagnosis. Yes, there are people who come in and they have self-identified already. They had ADHD and they do have ADHD. We agree with them after a thorough assessment. But there are people who may have recognized and they may not have ADHD. It may be something else going on. And one of the very important thing is ADHD comes comorbid. 80% of the time it comes comorbid with other conditions, whether it is anxiety, depression, personality personality structure, substance use, and so on. So there's so many disorders that can be linked with ADHD. So it's not at all wise to diagnose or put a label of ADHD in the first session, whether you're diagnosed or not. Both ways. If you miss the diagnosis, that's a problem, because the person may never go and seek help again. But if you overdiagnose, if you don't diagnose correctly, that's a problem too, because you're not only exposing them to medications which can have side effects, but that's also not the right diagnosis. So careful evaluation and diagnosis is the key.
And it's that same diagnostic process with other conditions as well, because I do understand what you're saying about you don't want to label people out of the gate, but you have to diagnose them to be able to medicate them. Like, you have to be able to explain to them what it is that you've decided that they have based on their symptoms. So you do need to arrive at that point, but what you're saying is you don't jump to that conclusion.
So there is one thing about putting a label, single label, for example, the person's got anxiety versus person's got schizophrenia. So that's two, one is very common and prevalent condition, and that's something more common, people will understand. But if somebody is said to have anxiety, very easily understood. But if somebody is diagnosed with schizophrenia or bipolar disorder or ADHD, that stays with them for a lifetime as well. So you got to be more careful on the impact. What is the condition that you're diagnosing the person with? Autism, for example, a general, I've heard the phrases like, oh, you don't look autistic, or, talking about somebody, or he doesn't look autistic. There is no such thing as look autistic, or the person is a doctor or lawyer, and how can he be autistic? These are the words I've heard. So these labels can define people. So that's why you have to be very careful in how you approach what's the impact of that label. So that's what I was talking about, not putting the label straight away. In psychiatry, it's all about understanding. It's about formulation. You understand their background. You understand what they're going through now. What is the chemical imbalance going on? What stage of life they are in? They're teens, they're adults, they're a pregnant woman, they are, a man who's just got, a relationship breakdown, or what's happening in their life. So all that is very important.
The cynical view is that we're now over-prescribing and over-diagnosing, and that people are looking for a diagnosis as an excuse. You do hear that as a alternative attitude when we talk about, particularly in the context of people being diagnosed with ADHD later in life. You might hear a throwaway comment of, oh, everyone has ADHD now, or essentially inferring that people are making it up because they're just trying to excuse their behavior. What's your response to that?
I disagree with this because the diagnosis doesn't come only with self-identification. The diagnosis come by a professional reviewing it, the diagnosis. So I have hardly seen any misdiagnosis so far. So if I've seen a patient who was assessed and reviewed and diagnosed by another psychiatrist, when they come to me, I have hardly still to see people who were completely misdiagnosed. There are exceptions. There are exceptions when people are having some other form of mental health condition and they may be misdiagnosed, and that's why the thoroughness and the proper assessment is the key. ADHD can be misdiagnosed, but if it's diagnosed after a thorough assessment, I don't doubt that it's a right label, or it's a right condition. Yes, one thing when we talk about the overdiagnosis, one thing we miss out is how's the awareness now? How many people know more about ADHD than if you compare just 5 years ago? Let's talk about 50 years ago. 5 years ago, if you talk about ADHD, not many people would, be interested to talk about it or know much more about it. In the last 3 to 4 years, that's why I use the word, pandemic, but it's the right pandemic. People are actually not having an idea about what's going on with them. The awareness, it's so important. People with ADHD have so much impact on their personal life. It's not only on personal life as well, it's a lot of impact on the financial situation of their own home, their family, their relationships get into trouble. There are impacts on the economy of the country. More problems, more days off, more less functionality, not able to be able to do things that they could do if they were treated, for example. So there is so many things that happens in substance use,
Self-medicating.
accidents, self-medicating, substance use can be there. Unfortunately, a lot of people in prison are known to have ADHD. Not
Impulse control.
Impulsivity is the reason. So if that's treated on timely basis, that we may see less of those accidents, less of the impulsivity, even less of crimes, if I dare say, that can happen due to the impulsivity.
So we're discovering that there's actually quite a larger percentage of the population that has this than previously thought.
That's being diagnosed, that's being understood now. People still had the same amount of prevalence a few years ago. It's just being more recognized now. People are coming to access the psychiatry services now, and people are able to be diagnosed now, be treated now, and get better.
I think it would be remiss not to mention the Bondi shooting. Can you just tell me about how those traumatic events can impact the whole population, from people who were actually directly involved to people who are just witnessing and internalizing what's going on?
It's one of the most unfortunate incidents in our history here. Hundreds of people were there live on the scene, and hundreds of thousands of people have seen those footages and things on TV and across, and there is probably nobody in the country or in the world who doesn't know about the incident. We are all very closely involved. We are all very closely affected by the incident, let alone be people who were there at that time, who were hearing the gunshots, whose relative was a victim, whose friend, who had known people. So there would be hundreds and thousands of people who would be somehow connected to that incident directly. Their family member was there, their friend was not there. So that is likely going to cause problems with mental health issues, anxiety, depression, PTSD. These sort of conditions can start or originate or surface after such horrible incidents. So in a system where supports are already stretched, it can be a problem. Good thing is obviously there are services, there are 24 hours helpline, lifeline, things like, a triage, mental health triage, emergency services are there for somebody who's feeling, to need to speak to somebody or feeling at risk. There are services there. I'm reassured that there will be more and more services coming in specifically to accommodate people who were affected by the incident. We can only do that much. I don't think that memory or that incident can be erased from our history. I'm obviously a migrant who came to Australia 16 years ago. This country has given me so much, and for the last 6 years I have dedicated myself to give back whatever I can. The country and the people adopted me with open arm as a foreigner. You don't see that sort of love everywhere in the world. So Australia is something I can't thank Australia and Australians. When a foreigner who comes here and everybody just adopts them for their for who they are, let alone be their skills and what they can add on. In Adelaide itself, I know over 300 to 500 Pakistani origin doctors, and everybody's busy adding on every day to see patients. Imagine those 500 doctors not being available today in Adelaide. How many consultation they are doing every day, how much are they adding every day. There are business people from my country origin, very proud. You were finalist in the Young Local Australian Hero of the Year, and that's a great, it obviously takes a lot to get there. The winner was Pakistani origin, female, just to mention. She's done a lot of work with women and all in the last 10 to 15 years. So there are people who are adding so very much, being thankful, trying to give it back. And there will always be people who shouldn't be identified with a country culture or religion. They don't belong to any religion. They don't belong to any country. They are who they are, and they do what they do, and they should be condemned at every level.
What's special to you about being Australian and being here, and what do you think makes us who we are?
The multiculturalism, the acceptance of everybody of who they are. It's not about where you come from. It's not about what you wear, what you do, what you drive, It's all about acceptance. When you go to work, you are just there, trying to help. Everybody's adding in. It's multiculturalism is at the core of Australia, and I enjoy it every day. My family enjoys it. I go out, I feel safe. I help out people. I feel happy. Personally, by trying to help out in the last 6 years since I've been involved in telehealth area, every day when I look at all the things we have achieved and added in even one person. I know we're seeing hundreds and thousands of people regularly, but if I add that, that's what makes me happy. That's what I know. A lot of people I know are trying to do the same thing, whether it's through any program they are working, any personal work they're doing, any charities they're doing, any jobs they're doing, or just going out and sharing a coffee or a drink or food. It's just acceptance. It's just getting to know that there are different people, there are differences, but we are all one. We are here. We should be living in peace. We should be respecting each other's culture, religion, values, whatever it is the person believe. We're nobody to criticize them. We're just here to accept them and be with them as a person, not for what they believe, not for what they do or
Yeah. Well, it doesn't matter what your culture is. We're all Australian, and there's just no place for fear and hatred here.
Absolutely.
If people want to access telehealth through your service, how do they do that?
Get a GP referral, easy. Get a GP referral and just call our service or email HelloDoc. It's admin@hellodoc.com.au. Send your referral, and within a day or two, you'll get a message and call, and you will be seeing a psychiatrist within 1 to 2 weeks.
Thanks for your time, Aleem.
Thanks very much.
That's it for this episode. If you like what we're all about, support us by following Young Blood Men's Mental Health on Instagram and Young Blood Mental Health on TikTok. Every podcast episode is recorded in professional quality video, and they're all up on our Young Blood Men's Mental Health YouTube channel. So please show some love and subscribe. You can find everything there is to know about the podcast at youngbloodmensmentalhealth.com. And most importantly, please share these stories with anyone in your life who needs to know they're not alone. We're all in this together. Catch you next time.